actually thought about the fact that she completely ignored the noise. It's a little bit narcissistic. Like she's so focused only on herself that she can't even, to the point where she said she raised her voice so she could be heard, that there was no thought about anything else going on around her.
Interesting. Yes.
I also had a similar, my reasons are different, but I felt very differently about after you said something, my opinion of her totally changed as opposed to when I first read it, I'm like, my opinion of her was one thing, and then when you said it, I still felt some of what I felt before, but it kind of glossed over. And what it seemed was, this is somebody who can't acknowledge what's going on around her. Doesn't have a voice, doesn't have permission. A very a person has number one. Before you said what you said.
What did you say to patient number 2?
Nothing.
No, what did he say? What did you say when she said that? When she said that?
I'm sorry about the noise today.
You're good.
Yeah. We're going to keep the event going now. You almost shut it down. You saved the day. Yes.
My first image of the first patient is somebody, people read novels and the ceiling will fall down and they're still reading. There's something about being so concentrated that you envy them for being able to.
A panemi is the term. A panemi is that they are so hyper-focused that everything else is. Okay, I'm going to tell you about these patients just because you're curious to know, but the point of the exercise is not that. The point of the exercise is how, and don't try to not do this, okay? Everything you're doing is what good therapists do, okay? Because it's human. We form elaborate fantasies based on tiny bits of information, okay? Tiny bits of information. That's what human beings do. Now, if we're a good therapist, we can revise our theory, okay? If you can't revise your theory, you're psychotic, all right? If you're stuck, well, yeah, it would be paranoid psychosis, but all of us with a tiny bit of information do form an elaborate theory. I mean, you're ready to make a diagnosis of attention deficit disorder, and one is passive aggressive, and one is very narcissistic, and one is so worried about me she's taking care of me. I mean, that is what we do as therapists, and it's very important to know that because you are reacting to all kinds of stuff with your patients all the time. It's one of the most precious tools you have as a therapist is your human reaction to the patients. That's really the point of the exercise. To tell you about them, okay, patient 1 is in fact someone with tremendous problems. It's not only authority, it certainly comes out a lot with authority, but a tremendous fear of people being angry at her and people yelling at her. I mean, she's so terrified of it that she really does not function well in life in any way. She's coming a long way in therapy. Any of you that would meet her would find her to be one of the most clever, creative, physically cool-looking, stylish, skillful, elegant young women you've ever seen before. That would be your response to her. She's a psychoanalytic patient. Okay, she's an analytic patient. She comes 4 times a week. She has problems, global problems in her life, despite enormous talents. And she's coming along. I mean, she is flowering, and she's sort of getting out of this trap that she's built for herself in life. Patient 2 is a patient who has suffered tremendous trauma, physical abuse, sexual abuse. She comes sometimes twice a week, sometimes once. I mean, she's scheduled for once a week, but she often comes twice a week. She also has a long history. She actually came to me as a pre-surgical evaluation for an elective hysterectomy. The gynecologist didn't want to do a hysterectomy, elective hysterectomy in a relatively young woman without a psychological clearance. So he sent her to me for that evaluation. And the evaluation, which was supposed to be a one-time thing, has turned into this ongoing therapy. And she has a long history of being, in her experience, abandoned and harmed by doctors. actually. Many, I mean, she's had multiple surgeries, she has psychosomatic illness, she's had addictions to prescription pain medications, and her life is one series of being abandoned and not taken care of by one ostensibly nurturing figure after another. Interestingly, she's married to a celebrity. It's a weird thing. She's married to a celebrity. Patient 3 is also a psychoanalytic patient. He is, I mean, when I say high-functioning person, he's truly one of the most brilliant people I've met in my life, and I'm not exaggerating in any way whatsoever. And he also is someone who was raised in a non-Jewish, totally fundamentalist, like outrageously fundamentalist religious environment, and he was beaten, seriously beaten for his entire childhood and adolescence, and eventually ran away from home like age 17. But he's become an amazingly talented academic, a very creative person. I mean, he's an amazing person. They all are amazing people, these three. But that is, that's what those three people are like. I can see how their personalities do fit with these three things. But, you know, that's cheating because I know them. And I think, you know, good, I would say 85% of the comments here seem plausible to me, of the fantasies about what people would say. But that is how we do stuff. Now, we're an hour and a half in. We're going to move to, or actually it's going to be Groundhog Day. We're going to do this again, is what we're going to do. We're ready to move to the workshop. What I would like to do is just get volunteers in advance, then we'll take like a 5 to 10 minute break because we have another hour and a half left. I would like 3 volunteers to play patients, and I want you to think of patients that have given you a very hard time in therapy, and I want you to be willing to portray your patient. Now, you can do so in any way that you want to. If it's someone that you're afraid of confidentiality, you can change facts however you want. What I want you to portray accurately is the way they gave you a very hard time as a therapist. That's what I want you to think about. And then I'm going to need 3 people to portray therapists that are going to do simulate an interview asking about the problems. I want you to try to portray the difficulties that these patients have given you. Okay? Can I have 3 volunteers? Does anyone, you want to play a difficult patient? You've got a difficult patient in mind? You have a difficult patient in mind? The rest of you have such easy patients? A third, you'll play, okay. Now I need 3 people to play therapists. Don't worry, the audience is going to do a lot more work than you guys are actually in this exercise, so don't worry. But who's willing to play therapists? You're willing to play a therapist? Actually, you are a therapist. I'm just kidding. Okay, you'll play therapist, and you'll play therapist. Okay, so let's come back. It's 10:35. Let's be back 10:45. Okay. I don't have a handout. I can send you the, yeah, I can send it to you. Yeah,
Can I
yeah.
take your email and
You can, because I have it on my card.
thank you?
Sure. Hi. Nachum Klafter. Nice to meet you. Like your comments.
Thank you. I was wondering, do you do a couples workshop?
I don't do couples work personally. I have a little training in couples work. I'm full, so I don't need to do couples work, and there are people that are so good at it that I refer for couples work. They refer me for individual work, I refer them couples work.
What do you know about like psychodynamic couples work? I mean, as opposed to like yesterday they had a workshop on psychodrama, very different.
I don't know a lot about the theory. I know a lot of excellent couples therapists that are trained in psychodynamics, and I think they're very good as couples. I think that there are certain techniques that allow you to work with a couple rather than doing like tandem individual therapy with people at the same time, that allow you to be like talking to the couple, getting the couple to do their processing in the room while you're there, and a psychodynamic understanding of what is going on in the relationship is what those people use, but they're using techniques that are very different from individual therapy because it's a couple they're seeing and not two people. I mean, that's sort of what I know about it. But I refer mostly for couples work. I know some great couples therapists, and we refer to one another.
And the ones that you're referring to, are they working dynamically, or are they working more like?
Well, I think they would say that they're working eclectically. They happen to think psychodynamically. I mean, two of them are psychoanalysts also, but they do couples work, and I think most couples work that I've seen is shorter term and solution focused. So I think they're doing, but I think I think they have a psychodynamic understanding of what people are feeling and processing, but I think that they're very problem-solving oriented and trying to, get people back together sexually, get people to move beyond bitterness about something.
Yeah.
And I don't see most of them working with people like years and years in couples therapy.
Right.
It seems like months
Right.
for the most part, as opposed to patients, they might work for many years.
Okay. Okay, thank you.
I'm just curious about you asked me why would you use humor, so I'm asking you why did you use humor? It didn't sound like you were describing too much of a different person. I also thought someone with a healthy...
I was just trying to figure out what your theory is. Like when Yehuda said, I think he's coping, he had a classical formulation. I thought that you were using a self-psychology form. I was trying to just hear what your gut feeling was about the humor, why someone would make a joke, and so that's what I was just trying to get you to say more. I didn't have anything. I was trying to.
Okay.
It was
and the
right.
truth of the matter is that I wasn't looking at it as a humorous remark. Maybe it's my defense because of the type of remark I probably would have.
You felt it was a hostile remark, or
No. I just thought it was an appropriate remark.
Yeah.
As opposed to saying because just saying what are they building up there.
An airport, right?
Without saying an airport may sound different. It's kind of like when you type a text message without any intonation and the person doesn't know.
It might have sounded critical.
It says, "Listen, I'm acknowledging that it's there."
What you'll see is in the workshop. What we're going to do is, I want to hear what people's imagination is behind the things. That's what I was trying to do. Just hear more about your imagination. That was my intent. I didn't have something in mind.
Say, when are they building their? He was creatively free associating, like.
He was free, yeah. He was making a joke.
Yeah,
he was making a joke.
He was also creative. He also has imagination. He's not concrete.
Right.
Okay.
Yes. Oh, okay.
I was just going to say about the first patient. Did you mention anything about her silence?
No.
So you just let it ride, as opposed to that's a stylistic thing.
I mean, I didn't. I see her 4 times a week. I don't have to work like right. What?
He doesn't talk to his wife as much.
His wife doesn't pay him. Do you like the old?
What'd you say?
Do you like the old psychoanalysis?
The new psychoanalysis is what I do. The new psychoanalysis.
You presented in your classical thing all the things that drive me, Chaya, all of us from that generation crazy.
Well, that's what all the new theories are about. I mean, that's what it's all about.
Regular talk therapy?
Well, I don't know. I mean, regular talk therapy, what do you mean?
Not kind of like they used to do it, like
Well, right. So when I do psychoanalysis, it's 4 times a week lying down on a couch, and it's for special kinds of problems. Like if somebody has like the first patient, for example. The first patient, she is terrified. She can't do mamish anything. I mean, she's brilliant, beautiful, creative, sensitive, funny. Everyone adores her. Everyone wants to sort of adopt her as their daughter. She can't have friendships. She is afraid of relationships. When she was a student, even though she got all A's, she doesn't even know her GPA, because when she would get a paper back from a teacher, she was afraid to read the comments, and she would just throw her papers out. And she tried to go to graduate school to get an academic degree to become an historian, and wouldn't read the comments of her professors. I mean, it's a crazy thing to do. And she has these problems in every area of her life. So once a week therapy, twice a week therapy was like inadequate. adequate. It just wasn't adequate to help her with those problems. I mean, it helped her to some degree, but the attempt is if she'll come 4 times a week for a period of several years or a few years, we can get her out of this and get back on track in life. That's the theory of. That's when you would use psychoanalysis, but it might be similar to once a week or twice a week talk therapy in terms of how you think about things and how you talk. But it requires just more intensive involvement because the problems are so severe and in so many areas of life.
But do you do free association? I mean, is that the function of how you do it, or is it talk therapy just more often throughout the week?
Well, free association is a helpful technique. It's a helpful technique in talk therapy too. I mean, it's a helpful technique.
Is with classical psychoanalysis is that much of the time is spent with the patient who is talking and you're taking in information and occasionally making certain interpretations of what they're saying. Is that how you practice?
It would be more like this. It would be more like this. It would be, I'm glad you're saying this because I might maybe say something on this before we get started. It would be more like this. The task is free association. So let's say, lie down, try to tell me everything going into your mind in real time as it's happening in your mind. Try not to edit in any way whatsoever. Sooner or later, probably. What'd you say?
Closed eyes?
No, don't have to close your eyes. I mean, there's no rule, but you don't have to close your eyes. One of the reasons to lie down, though, is so that I won't be in the person's visual field. Now, sooner or later, you're going to have thoughts that you're not going to be able to tell me. You might know that you don't want to tell me, and then you'll talk about that, or you might just notice yourself. And my job is to observe with you when you get stuck, and to wonder about that with you. And then what we'll see that your inability to keep associating will reveal fears and difficulties that you have, things that you don't want to know yourself, things that you don't want me to hear, things that you're afraid will come out, and it will very quickly recapitulate what the core conflictual relationship thing is. It's just a technique. There's probably more talking done by the analyst than people imagine because of the way analysts used to write about their work. There's a lot more talk done. I mean, you hear me talk. I can't be quiet for very long with patients, So, but yeah, free association is definitely a central technique in psychoanalytic therapy and analysis.
Is it still being practiced today?
Yeah, I mean, I do it. Yeah.
Isn't there
it's a big part of what I do.
Large spectrum of. I'm an analysis. I'm an analyst myself, and I do like 98% of the talking.
Okay.
I would imagine that there's a big spectrum of.
Well, there's people's styles. There are people's styles, and there's also some patients have a need for more intervention than others. I probably, it's more than 2%. I'm talking more than 2% of the time. It's probably more like 75-25 if I had to guess, but it's different with each patient.
I just wanted to say something. It's Moshe wrote and spoke in the email.
Oh yeah, nice to see you in person. Right, nice to see you. Hi, nice to meet you.
The therapy there to try to make the patient feel safe and get to
Well, the patient has to feel safe so they can talk in therapy. So that's one of the important techniques, is to make a patient feel safe. It's not the fundamental goal. It's necessary and not sufficient.
When they get stuck at one specific point,
well,
on one hand you want to analyze, and on the other hand, this is something that doesn't want to get into.
Well, we're going to talk about that now. It's most helpful to try to help them understand what they're worried about. In other words, you're worried I'm going to judge you. What do you imagine I'm going to say? What do you imagine I'm going to think? I understand that. Can you tell me about why you don't want to get into it right now? What does too scary mean? Like, what will happen? You'll feel scared, or you'll, like what?
You're gonna try to get into it around.
No, I'm trying to understand the nature of their resistance. That's what I'm trying to do. In other words, am not trying to force you to overcome the resistance. You know what I mean by the resistance? The monea, the monea. Like in Hilchos Shabbos, you know hasaras hamonea is? Do you know what that is in Hilchos Shabbos? Hasaras hamonea. You're saying let's remove the obstacle. Making someone feel safe is remove the obstacle. I want to understand the obstacle because that obstacle is the same thing that's causing problems in your life.
Right.
In other words, when you're shy and you won't go out on a date, that is the same problem in my office. I don't want to get rid of it in my office because I want to understand it, and then you won't be trapped by it on your date.
Then are you going to get into the black box and find out what?
Well, we're going to learn together. We're going to discover together by talking about it. I feel like this. I feel like that. It reminds me of when such and such happened to me. Everyone always thinks I'm like this.
And that itself will give them
That's therapy, freedom in their lives.
And then he might be able to talk.
Right. Okay. Hi.
I just want to make sure you know the fewer questions you take in middle, the better audio you're going to get. And if someone does ask questions, if you repeat it.
All right, I'll try. I mean, this is not going to come out well. It's a workshop now. It's going to be, you know what I'm saying? It's just hard.
Yeah.
Yeah. Right. I hear what you're saying. Yeah. Unfortunately, I'm not. The way I do it doesn't translate well to a good tape. It would be better like if we gave everyone microphones or something, it would work. Oh, you know, I could do. Oh no, I could. Right. That's what I'll try to do. All right. I could. Okay.
Didn't think that I was trying to find the single flaw in what you presented.
You wanted to kill me.
No, I did not. That was not my.
No, I'm using
and you don't like him, so you won't incorporate.
I'm using an experienced, distant, classical formulation of what you did. That's what I'm doing.
Hardly. No, I thought it's also the age difference. Like you don't think about it.
I was thinking about that. I didn't want to get into it though. Right? Yeah.
Absolutely. Turning
But
60 is
the other thing is this. Here's my real answer would be this. It is addressed in self-psychology because the idea of having meaning in your life, there's an endpoint in your life, and when you start to see the endpoint, it changes the ambitions and the anxiety.
I think that
it is part of self-psychology.
Yes, I know that. But
Okay.
I think it really needs
All right.
to be.
It's not in my mind. It's in the theory. It's in the theory.
It's not on your mind because you're 40. And
That's right. I'm still a young one.
Yes, but also you probably have better denial. You probably are more like her, who has
Just go and go and go.
death mechanisms.
Right.
And I have very poor ones from the time I'm born. Probably because of my mother.
Okay, so we're going to get started.
I can tell you later.
Yeah.
I mean, I read you and listen, you know, and I find you very thoughtful.
Oh, thank you.
Thoughtful.
Thank you very much.
And Jamie, I was expecting an older person.
Oh,
Yeah,
okay.
just saying.
Thank you so much. Thanks.
Where in the Midwest?
No, in Rochester, New York.
And how do you come to Cincinnati?
My job. I got hired to teach psychotherapy there. It's like I have my dream job. Momish, my dream job. You know, it's 1/4 the salary, but other than that, it's my dream job. That's true. Everything's lower.
I want you to know, Dr. Klafter, that I'm just on with Chaim, that I so rarely read any of the emails. If I go on, I read your emails.
Thank you so much. That's so
really
nice.
Find them, no, I'm serious.
Thank you.
They're profound. They have some. They're useful. There's something in them. There's tochen.
Thank you. Anyone know how to turn this off?
Off?
Yeah.
What says off? How?
It says standby, but it's not going off. Because it's going to be in people's lives, and it's hot, and it's yeah.
Power off. Question.
Oh yes. So does it say yes anywhere? There, it went off. Good. Got it. Okay. Excuse me. Could you help me move this for a second? I want to move this out of the way. Be careful of the cord over here. Thanks. Thanks. Okay. All right, so there's a couple. We're going to get started. There were a couple questions that were asked to me during the break, so I just wanted to address one of them, which will help some people. One of the questions was, to what degree is psychoanalysis conducted according to the fundamental rule of free association, even contemporary analysis? Now, what that means is, I'll move this out of your way. What that means is that the patient is assigned a task. The task is try to tell me everything going through your mind with no editing and in real time as you're experiencing it. Everything you're thinking, everything you're feeling, anything you smell, whatever you're, try to just tell me what's in your mind, like if we had a microphone in your mind and you could put it into words. And what happens is that very quickly, people are unable to say those things. They're not aware that they've shifted their attention. It's embarrassing and I don't want to talk about it. It's a technique to help people see that they have defenses intact to spare them anxiety, embarrassment, a sense of loss, all the things that we were talking about in the presentation. So that's what it's a technique. And the answer is that psychoanalysts still do use free association as a very helpful technique. It's not a rule, it's a technique. Many therapists also use free association. Other therapists will just have patients talk about, whatever they want to talk about, or talk about this specific problem that you've came in to identify, but it's a technique that helps people see that they have forces at work that sort of shut their mind off or act as a censor. And then why is it that this particular issue would cause you to have this anxiety? That is a very central technique in psychoanalytic therapy and psychoanalysis itself. One question, then we'll try to go on to the workshop. Yes?
Do you use dreams as well?
Yes, I use dreams very much. I mean, in fact, in the range of analysts, I probably use dreams. I'm on the extreme dream. I'm a dream boy. I use dreams a lot, a real lot. And my patients seem to know I like dreams because they start having lots of nice dreams to make me happy. So I have very nice patients. They're very good people. They do take care of me. They all take good care of me. The ones that don't, they seem to just, I don't know, they don't come back. Something happens. So, all right, you were first volunteer for a difficult patient, and you were the first volunteer for a therapist.
Last volunteer.
For a therapist.
I'll do it. I mean, but if somebody else.
Who were then? Okay, well, okay, we'll go anyway. Let's have you guys come up. Does anyone have a dog phobia?
Yeah.
I'm there.
Yes.
He has a people phobia.
Oh. Okay. So, all right. So I'm going to interrupt you and be asking some questions, but we're going to let this is your office, and she has just sat down for the first time. Let's see what happens.
So we're starting the interview. This is the first time I'm meeting you. Hi, welcome. Why don't you start? Tell me a little bit about what brings you here, what your concerns are, and what you're looking for.
My therapist said
I'm going to give you guys the microphone. That's what I'm going to do. We can put it back and forth.
my therapist spoke to you.
I'm not sure who your therapist is, so I don't know if I spoke with her.
Klein, Matthew Klein.
No, I think I may have gotten the phone message, but we haven't connected yet. So
I'm sorry, I don't have any information.
But my husband, he's depressed.
Okay, let's stop here for a second. Okay, so does anyone want to comment on what has happened? There's been basically 2 exchanges that have happened so far. Can anyone just share with me your observations or thoughts about those 2 exchanges?
Have you thought of me before I got here? Did you have information? Are you asking like what's going on psychodynamically? Or
I'm just asking for your observations.
observations are that she's asking her new therapist.
Did you talk to my therapist?
Right, as in.
Okay, and I think that the therapist was confused. Did you feel confused? You felt confused.
Yes.
Okay. Now we've all met people that do that. You know that.
So comfortable. They're so comfortable confusing their therapist.
right. And so I think that was confusing. All right. So I mean that would be to me the first thing I imagine you're feeling. That's my vicarious introspection. Maybe even in the exercise it's confusing. All right. So confusion. It's like, has my therapist talked to you? Well, I'm a therapist. Aren't you coming to me to possibly see if I can help you? What are we doing? Do you have another therapist? Am I getting into this situation where I'm going to be like one of 3 therapists? What is going on? That's what goes through your mind. Okay, now that is, we could call it we could call it whatever we want to. That's your emotional reaction. Now, it is also, this patient you're portraying, I think it's weird. That's a weird first response. The patient you're portraying is a little bit.
The truth is, this patient, the therapist, did actually speak to her therapist and did refer her.
For another.
Give some information.
But for another therapy or for.
The therapist felt that at this point she cannot work with her.
Okay.
And she did refer her.
Right.
So this new therapist should have gotten some information.
So the first thing that's happening, I think, would be that.
There would not have been confusion, is what she said.
No, I think it would be very confusing, in fact, because how many patients, have you ever been at a clinic and all of you have been at a clinic, and the last person that graduated before you leaves, all right? And you get a patient, and what do they say? Well, didn't you read my chart? Didn't you read my chart? What is in the chart? What honestly could anybody read? It's not legible. It's not there. I think it is.
I've never read their chart.
It's not going to substitute for, and that's one of the first things is like, do I have to tell you my story? Can't you just get the data from some other source? And it is confusing, and not all patients operate that way. I think that other patients will say, well, and they don't care that the therapist has talked to you already. They'll say, they're not inhibited. They'll just say, well, I was seeing, Dr. Klein. He wasn't helpful, or she wasn't so helpful. It's not working well. We think that we need a change in what's doing. So I'm coming to you to see if you can help me in a way that Dr. Klein wasn't able to help. That would be the way. So there's some inhibition that you can't. This patient can't do that.
For sure.
And it's confusing to you.
Right, and the other thing is it's also when when the patient says, "Didn't you speak to it?" It's like an immediate, you haven't done what you're supposed to have done.
You're exactly.
And it's like, well, I did get a message, but I'm not supposed to know. So it's how do you not react defensively? It puts you on the defense, but you want to yet make the person feel welcome. So it's like, okay, I understand that that's what you would have hoped for, but we just haven't had a chance to do that, which is a way of saying, I want to be responsive to you, but I didn't even know that was what the issue was when I got that message. So it sets up a very complicated dynamic from the beginning.
So we're going to just move on a little bit, but this is resistance. This is resistance because the patient, the client, does not want to tell her story. Okay, the client wants to have other people do this. The client is inhibited from telling her story.
Exactly.
We're going to go on. Let's go on. Yep. Okay. Okay. So.
You've interrupted the process. So.
How does that make me feel when you say that to me? Okay, so go ahead.
So I'm not, so I'm sorry that I haven't had a chance to talk with Dr. Klein. So why don't you tell me a little bit about what work you were doing with Dr. Klein and what the concerns were and where you felt you got stuck.
My husband was depressed, very depressed. He's on medication now. She helped him to go to psychiatry. It was very good that she, since I started going to her, I'm a different person.
Really? In what way?
Like I never knew that if I was upset, like I just didn't know it. I never knew it. I always like to make everyone happy around me. And I was like, my husband was always upset at me. And I always thought it was my fault. And
so through going to Dr. Klein, what do you realize that not everything's your fault?
yeah.
And how did Dr. Klein help you become aware of that?
I'm going to stop for one more second, too. Okay. So any other thoughts about this? Okay, so the story's unfolding, kind of. Yes?
Her first presentation was about her husband as opposed to her.
My husband was very depressed.
So that's about
He took an antidepressant.
It wasn't about her, it was about her spouse. And then she goes into what Dr. Klein has done for her, but the original question wasn't really answered, which is why is she here?
Right.
It kind of went all over the place.
Okay. You had a...
She was like, probably being like she is with her husband, being very passive and getting the therapist to try to lead her along, when the therapist would have no way of knowing which direction she should be led.
So that's what you feel like is happening. That's your formulation of what the patient's doing.
So it's sort of like actively being passive.
I had a very different reaction. I had a very different reaction. My reaction was, she's telling me my difficulty is in not knowing how to deal with my depressed husband. And that what in fact she told me was, I didn't know how to deal with him. And in part, the reason I didn't know how to deal with him is because I had no idea what was going on for me. And what I got from Dr. Klein is that Dr. Klein helped me become aware of what's going on for me inside. And because I've become more aware, sort of like I ate from pre-ate a da'at, now I don't know, now what I don't know and what I was sensing was, now that I know what's going on for me, now I don't know how to deal with it. And that's what I got from, that's what I got. And it didn't feel to me disorganized. It felt like her own internal experience.
Okay, but
This is her reaction.
I want to say that I don't think that's inconsistent at all, because the problem, if this, I mean, I have the same sense of you, but if that's the problem, if this is a person who has been unable to state her needs, her pain, her difficulties, and she's coming to see you, and she can't tell you why she's here. Didn't you talk to Dr. Klein? Okay, no. Well, my husband was depressed. We are seeing right in the therapy it's very quick, okay? Now we don't know, so you've developed this theory. We don't usually get the theory that quickly about it, but we do see right away that her difficulties are being illustrated in just simply telling the narrative of coming in. I mean, that's the defenses, whatever the defenses are against knowing that you're upset, knowing when you need help, knowing that you're anxious, are now inhibiting your ability to relate the story to the therapist.
But she is relating the story.
Well, the therapist is listening empathically and making a lot of conjecture, but it isn't, it's difficulty. I mean, what we're hearing is that she's relating it through her difficulty.
Oh, absolutely.
Right, exactly. Okay. But it's her inability to relate the story that is how we're learning. It's her inability. The story is her inability.
How she's doing.
Yes.
It's the process.
Yes, the process, it's the inhibition from communicating that's the story. Right. That I can't tell the story right now is the story.
Yeah.
Yes?
I've been impressed from the moment you sat down, sorry, I don't know your name, but and the body language.
Yeah, that's her.
Exactly. I mean, the minute you sat down, even the way your head
gets caught. I mean, just everything
That's her.
kind of reinforces what you were interpreting.
Now,
I mean,
that,
Tony's doing a
right.
great job, yeah.
Now that thing she's doing, I want to make a comment because I've observed this during this conference and I've observed this in general. Whenever we do role-playing exercises, everyone is amazed at how awesome the acting is. I was at a psychodrama workshop, that's what everybody said. Have you guys been preparing for this? You were at a psychodrama workshop, they said that about your workshop. In supervision, I mean, there's a phenomenon, there's a paper called the melding phenomenon. I don't remember the author, but it's that if you ask your supervisee to take on the role of a patient, they will go into unbelievable, and at a certain point, they won't even know, they won't be able to break character because they'll be fused, and they can't remember, I don't know, was I talking about my patient or was I being my patient? This is what happens with our patients, and it always stuns us. I mean, I don't know what to make of it exactly, but it always is significant.
So often, I can mimic my clients to the pin. You know, it just happens that way. You're seeing it over and over. It's like I used to be in plays, and you rehearse. You're rehearsing it, and if you see it,
You're studying. You're doing a character study. Okay, so we'll go a little bit further. Let's jump into now. I'd like you to start talking about, try to portray a session where you felt it was very difficult to work with her, whatever the cause was. Just start talking about
the therapist.
You as the patient.
Oh, me.
Yeah.
1 minute.
So
So I have to be now who?
you're the patient.
You're the patient, but I should do one of the most difficult sessions. I should bring in. Let's say session number.
Just think of a characteristic session where your patient was. You found it difficult to work with your patient. Try to capture what your patient was doing. Start talking spontaneously.
So we're going to skip now to fast.
Yeah. Yes.
Okay,
right.
So
Go ahead. Right.
We had a, okay, you can ask me how my week was.
So where would you like to begin today?
I don't know.
Were there thoughts or issues that came up during the week that were difficult and you thought to yourself, oh, I'd like to bring that into sessions? Maybe? Can you think back to some of the feelings that you might have had during the week that were either more difficult or more stressful? Because I know that sometimes you've had difficulty. One of the things we've been working on is difficulty knowing what you're feeling.
No, since my husband's on medication, I really don't have such a problem. He's going to start therapy, maybe the one you arranged for him, maybe in 2 weeks.
Okay, let's stop here for a second. Okay, so what are people's observations about this?
His medication cured her feelings. That's amazing.
I have a question. When you said,
My next place I was going to go.
when you said,
Medication, so you have no feelings.
when you said,
Not vicarious introspection.
right, when you said you can ask me about my weekend.
I spoke about his medication.
Were you? No, I want to know. Were you in character as your patient then, or were you?
My patient. Oh no.
Okay.
I was not a patient.
That's what I'm asking. You were just saying this will get it started. It'll get started.
But she would never start talking about her week without the therapist asking.
That's what I want to get to. Okay, that's what I want to get to.
But even when you ask her how her week was, never an open-ended question will get an answer. Never.
Okay, so we heard basically not any content, right? Like what is going on in Janice as the therapist? The next thing she says is, well, were there thoughts or experiences or events that happened that you thought maybe you'd talk about since the last appointment? What is she doing when that happens? What's she doing?
Who, the therapist?
Janice, the therapist.
She's trying to suggest to her that during the week you keep in mind what you want to tell me next time. Did you say that? That was a foreign concept, I think.
Okay, so one.
Was there something you thought of it? Oh, I'll bring this up in my next session. That's very sophisticated.
So she's modeling. That's what you're wondering. It's like psychoeducation. This is how to do therapy. Think about stuff during the week worth talking about.
With a client like this,
You have to do that.
one of the things that I would have done in the very beginning was to explain, you know, I would have processed with her how she worked with Dr. Klein and how I work. And these are the things, because she would have identified, I don't know what my feelings are. So I would have, part of what I would have done would have been maybe one of the ways to make this time between us useful is to do that.
Okay, now I want to stop here. This is what I want to ask everybody. What is you've heard few vignettes of this patient that is very inhibited in her communications to the therapist, all right? What is your theory? What is your hypothesis? What's your fantasy of why? Okay, why can't, I mean, I'd like nothing more than to go in and say, yeah, I saw Dr. So-and-so, it wasn't good, now I'm going to try you. I mean, it would be no problem for me, right? Why does this patient have such a problem doing this? What are your theories about that? Why can't she do that? She's uncomfortable with herself. And how does being uncomfortable with herself translate into not being able to talk in this way?
Confidence with their own feelings. I mean, this is what I felt, or this is what I felt. There's no feelings at all. Introspection.
So she doesn't have a sense as to what's going on inside of her. She doesn't know where to begin talking about it. Yes?
She's shameful about her own feelings, and she's blaming everything on her.
So even similar to him, stronger, she's ashamed of feeling sad or feeling worried.
More than, yeah, also denying it. It's not her fault, so it's only her fault.
Yes?
She has two things going on concurrently. On the one hand, she doesn't have a language, she doesn't have a way to communicate. She's not, it's a muscle, something you have to learn how to do, how to process your existence. And she probably doesn't have that. And it also depends how long she's been in therapy. I mean, there's a lot of other factors. And the other thing is she doesn't want to take responsibility. Like, she's waiting for the therapist to kind of do it for her. And if you keep asking, like, well, I mean, you have to wait out the client, but there has to be a moment of, like, giving her the encouragement to take some ownership of that.
Let me go to one thing you just said. Okay, so she doesn't want to take responsibility. Now, let's just, for 1 second, I'm sure that it's not that she doesn't want to take responsibility. Why can't she take responsibility? What's your theory about that?
And she is trying. We have to remember that.
Well, yes, but she may be coerced there. I don't know. No, right. I'm just trying to help this work with the resistance. Okay, that's a good observation. Why can't she take responsibility? What's your theory about why she needs the therapist or wants the therapist to do that first?
Well, there's no internal structure for it. There's no place to hold it. There's not
So it's a deficit? That's what you're saying?
Yeah.
Okay, so yes.
My sense is that she's petrified of being in touch with her feelings because the dyad, the marriage, and the husband, by focusing on the husband, if she acknowledges her own awareness, she's destabilizing the whole relationship.
Okay, good. I wanna. You can't at the moment. You can't yet. I want to go to these two comments. Okay, these are two. I mean, these are very similar observations. One is a conflict theory. One is a deficit model. Okay, she lacks the internal structure versus she is afraid of some negative experience that's going to happen if she will try to do this, and that's why she hasn't developed the internal structure. Do you hear the two different? It will change how you intervene. Okay, it will change how you intervene. I think the interventions, if it's a deficit model, will be like trying to give suggestions as to how to do this, trying to help suggest structure. The conflict model will be, it would be something like this. It would be, when you come in, I've noticed, when you come in and I don't give you anything specific to talk about, it's like very hard for you to start talking. And I'm happy to give you suggestions about what to talk about to make it easier to talk. But I'm just wondering if you could share with me what it's like. Like, are you nervous? Are you worried about saying the wrong? Like, what's going on? What's going through your mind when I say, how was your weekend? I see your wheel spinning. I see you staring. I see you thinking. What are you feeling like when I do that? That would be, what would she say?
She would say, I don't know. This is why it's good. When I went to the other therapist, like, I didn't know anything. Sometimes she told me to write down things. and it was so helpful. Now when I'm here, it helps me a little bit, because I myself, I don't know. Oh, where's that paper? I think I'll check my back book. I think once when I was there, we wrote something down. Where is it? Why can't I express myself? I don't know. I can't express myself. That was the first feeling sentence in 5 sessions that I heard from her.
So okay, and now Janice had a comment you wanted to make.
I'm sorry, Chaya's not here, because Chaya would say systemically, the piece that nobody has mentioned, and is how are Haredi women trained in terms of being able to speak about certain feelings, and how does the sociological role of this Haredi woman fit into her experience? And I don't think that can be ignored. And I'm not trying to cast aspersions that all Haredi women are repressed or anything like that.
She is extreme.
But I think that there are. I think you can't ignore the fact that the role of.
And I don't think it's Haredi.
It could be applying.
You have a.
From her past.
I'm gonna.
If I'm dealing with a Haredi woman, I have to look at what's the system.
I am dealing with many women right now. Okay, what do you want to say? Yes.
I want to say that partly I think it's cultural, but I think partly she doesn't feel safe because she probably never was able to talk about her feelings. Like she came home from school, a teacher yelled at her. She could not tell her mother, teacher yelled at me, but maybe she would have gotten punished.
She wouldn't have gotten punished, but there was no feeling.
There was she was never allowed
no emotional interaction.
To feel, and if she was why, you're not allowed to feel like that, or you shouldn't feel like that.
Okay, but we're getting caught up in understanding right now. Okay, right now we're getting caught up in understanding to what degree is this cultural, to what degree is this context. What we want to focus on is what to do exactly. You're in the chair as a therapist. It's different than, because it to some degree, it won't matter the cause. There are certain resistances when someone won't communicate you have to deal with, and you don't know the cause yet. You're not in a position yet to understand the context. You have to try to understand how are we going to work together. The work is frozen.
But what about the idea that if it doesn't feel safe, then she's not going to be able to move forward?
But what are you going to do? What are you going to do to either make it safe, or what are you going to do to help explore with her why it doesn't feel safe? Those are the two. I mean, it doesn't matter why at this point yet. We're learning that it seems to not feel safe. What are we going to do exactly in the moment? And the understanding of why will come probably later when we hear more. But right now, like, we're frozen, I think.
So what can the therapist do in order to make her feel safe so that she keeps saying, she said, I can't express myself.
She only said it once. It was the richest sentence I ever heard from her.
Okay, well, I don't know that the answer is to make her feel safe. Certainly, if a therapist makes a patient feel unsafe, it's gonna really be harmful for the therapy. But your responsibility isn't only to make the patient feel safe. It's also to try to understand with the patient and help the patient see her feeling of unsafety. That's part of, I mean, that would be, I think, you try to make a patient feel safe, but at a certain point, it's inevitable. And since this is her problem, it's not a bad thing that she doesn't feel safe in this office right now. It's actually like a very special moment, because it is safe, and her feeling of unsafety in a safe setting, this is like the best opportunity to see why she feels unsafe right now. Now, I think that's what I hear Janice basically trying to do. Like, the first thing is like, okay, does she not know what to talk about? Is that why? So maybe I'll give her some suggestions for what she could talk about, and then we'll see how she can do with that. So then she listens more, still doesn't get very much, wants to understand. That's what I hear happening. It's like you're back and forth between trying to help facilitate and then understand what's the wrong? Like, why isn't this working? Why isn't this working? The context or the culture might be part of the answer, but the truth is that we all know a wide range of very inhibited people from every culture and very aggressive, outgoing people from every culture. That's the thing. So we could go on and on, but we had two other volunteers, two other sets of volunteers. Thank you very much.
It was terrific.
Yes, that's great. Okay, another patient. Who was another patient volunteer? Two volunteered. Did you volunteer as a patient? A patient. Oh, you volunteered as a patient. Okay. Who was another therapy volunteer? You were. Okay. You'll go last. Achron Chaviv. Don't worry. Okay. Okay, so I'm going to ask you to do this. I'm going to ask you to move to a session where you were having a lot of trouble with the work. Try to portray what your patient was doing or talking about in that session. Do you have a loud voice, or do you want the microphone?
Had trouble with what work? I'm sorry.
Therapy.
This is a patient he had difficulty with.
He's going to portray the patient.
Change season, it gets confusing.
All right. We'll have you switch back. Switch back. I am creating a sense of safety in the workshop right now. That's what I'm doing. Okay. Okay, go ahead. Take the microphone. Can you? Okay. All right. Shh. Okay. Use the microphone.
I am so frustrated. I'm just so frustrated.